Start.
Great, thank you so much, Alana. So I'm Hetal. I think most people will know who I am. I'm a specialist respiratory pharmacist and work for the medicines management team and the co-lead for respiratory medicine at City and Happiness. I'm going to turn my camera off just so I'm not distracted by my own face. So firstly, thinking about the CO2 emissions in the NHS. So as most of you will know, the NHS is one of the largest employers in the UK, and it contributes to 5% of the gas emissions in the UK. Of that, 5% is attributed to anaesthetic gases and metered dose inhalers. So today we're going to be talking about metered dose inhalers essentially, and how we can try and reduce the carbon impact of those. So just putting things into context, we know that DPI, a dry powder inhaler, is far better in terms of the carbon footprint compared to a metered dose inhaler or a breath actuated inhaler. However, if you think about this in the context of exacerbations, our treatment aim is to reduce those patients traveling by car, either to the GP practices or to the hospital emergency departments. So our aim of treatment, regardless of what the carbon footprint is to reduce exacerbations and emergency visits, keeping this in mind. Let's have a look at what PMDI prescribing is like in England at the moment. So if we look at short-acting beta agonist prescribing, we prescribe on average almost 22 million salbutamol inhalers a year, 94% of which are metered dose inhalers. In comparison, Sweden only prescribe 10% of MDIs that are short-acting beta agonists. Again, when we look at inhaled corticosteroids, 94% of our inhaled corticosteroids are metered dose inhalers, compared to only 15% in Sweden. And again, when we look at combination inhaled corticosteroids with long-acting beta agonists, 47% of these are metered dose inhalers, so a bit better than the others, but that is still significantly higher than the Swedish population, which only uses 13% of metered dose inhalers. Overall, at the bottom, you can see 70% of our inhalers are metered dose inhalers compared to only 13% in Sweden. So I absolutely love the James Bond movies, but we can see here that when the Schiffer is at the gambling table with James Bond, he reaches out for his blue inhaler and takes a puff. Actually, as disappointing as this is for me, this probably represents how most people use their blue inhalers. We can see from this diagram here that inhaler technique has actually been consistently poor over the last 40 years. So this is a systematic review that was published in 2016. It included nearly 60,000 inhaler technique checks and concluded that over time, the number of patients that continue to have good inhaler technique is about 31%. There was a slightly higher rate of poor inhaler technique with PMDIs, but actually despite what device patients were using, whether they were PMDIs or DPIs, patients continue to make critical errors using inhalers. One way to reduce inhaler technique errors is to ensure device consistency with preventatives and reliever inhalers. I believe some of the reluctance in using DPI short-acting beta agonists is that there is a degree of inspiratory effort that's required to activate the dose. However, we can see here that all of the dry powder inhalers have a degree of inspiratory resistance. And this is something that I've only just very recently learned, that the lower the inspiratory resistance, the higher the inspiratory flow rate that is needed to be generated. So actually, when patients are using DPIs with higher resistance, they require lower inspiratory flow rates. There is also evidence to suggest that dry powder inhalers with high resistance tend to produce greater lung deposition than those with lower resistance, but we don't really know what the clinical significance of this is yet. We also also know that patients that are using higher resistance inhalers are more likely to achieve good inhaler techniques. So very similar to that systematic review that I showed you earlier. So this is published very, very recently in the UK, where inhaler resistance was matched using patients' current preventer inhalers. They used in-check devices for almost 1,000 patients that were recruited into the study. What they found was that patients that were using high resistance inhalers were more likely to pass using this inhaler check device with 93% compared to patients who were using PMDIs, which only had a pass rate of 70.5%. This was shown to be clinically significant. Or statistically significant rather. The reason for this was that patients that were using PMDI inhalers actually had inspiratory flow rates of more than 60 litres per minute, indicating that actually perhaps a dry powder inhaler may have been a more suitable device for them. We also know that, as I showed you in that Le Chiffre video, that most patients don't use a spacer device. And if they're inhaling in the same way that he was, a lot of that medication is deposited in the oropharynx and at the back of the mouth. And then it's swallowed and deposits in the stomach, as you can see on the left-hand side of this diagram. So if a PMDI is the most appropriate device, then each of these patients should be prescribed a spacer device. In this case, if they do inhale really hard, if it is an aero chamber device, which is what we usually use in our formulary at City and Hackney, then the aero chamber will whistle, indicating that the patient is breathing in too hard. So with a PMDI, a soft, gentle inhalation for 5 seconds is required, ensuring that the spacer device does not make any noise. Just focusing on asthma for now, before I come back to inhalers in general. So this was a survey done by Asthma UK and was published in 2019. This is just some of the results that I've included here, but they surveyed 13,000 patients looking at various things around their inhaler use, looking at their socioeconomic status, but also looking at their asthma control. Overall, you can see on the right-hand side here that only 18% of patients with asthma had good asthma control. When I say this with a little bit of a pinch of salt, because the good asthma control here was defined by patients not needing to use their salbutamol inhalers, not waking up at night, not having any exacerbations, and being able to exercise without any limitations. What I find in general practice is that when we ask patients these questions using something called the asthma control test, they will answer that they're waking up at night, they're using their salbutamol regularly, they have limitations on their exercise. But actually the last question is, how well do you think their asthma is? And often the answer is, their asthma is well controlled because they control it using their blue inhalers. So one thing that we need to be aligned with is what good asthma control looks like. And actually, when someone has good asthma control, they should never be needing to use their blue inhalers. We found with the National Review of Asthma Deaths, which was published in 2014, that actually the converse was true. Many patients with asthma were highly reliant on their salbutamol inhalers, with 39% being prescribed more than 12 inhalers per year, and actually weren't using their preventer inhalers very much. So 80% had fewer than 12 prescriptions in the last year, and 38% had fewer than 4 prescriptions. And actually, this is probably a good representation of what the current situation is. We know that patients think that their blue inhaler helps them, and they don't really know what the indication of their preventative inhaler is. I'm just going to play a video now, which helps us identify some of the conversations that we might want to have with our patients to help them understand what good asthma control looks like.
Many people with asthma question why they need to take treatment every day. It doesn't seem to make sense. They are advised to take a preventer inhaler every day, but their symptoms come and go. They may have days where they feel off, but more days where they feel fine. Taking a treatment every day doesn't seem important. Let's see why taking a daily preventer treatment for asthma makes sense. Often people associate illness with weakness, and not being able to enjoy life to the full. You might think that someone with asthma has weaker lungs than someone who doesn't have asthma. But that's not true. Asthma happens because your lungs actually react too strongly. The symptoms of asthma, like wheezing, chest tightness, coughing, and mucus production happen when the lungs are trying to defend themselves against attack. Let's think about someone who doesn't have asthma, goes to the Arctic in winter. The freezing cold air could irritate their lungs. The lungs defend themselves in a natural reaction. This would feel uncomfortable with chest tightness and coughing, similar to asthma. For people with asthma, their lungs trigger their natural defense too quickly. They react to common things like pollen, animal fur, cold weather, exercise, stress, and many other factors. They are different things for different people. The bad news is that over time, this can lead to asthma symptoms, but also damage the lungs if not kept in check. The good news is that we have effective treatments that can bring the lungs back into balance, thus reducing asthma attacks and preventing lung damage. To restore the balance, we use nature's way. Your preventer contains medical steroids, and these are like our body's own natural steroids. Steroids help to prevent any organ, such as the lungs, from overreacting. So the steroid in your preventer inhaler can actually be seen as a top-up to your natural steroids. The amount of steroids in each dose with a preventer inhaler is tiny compared to steroid tablets or injections. Although people sometimes worry about steroid side effects, the risk of side effects with your preventer inhaler is very small because the daily steroid intake remains low. This relatively small amount of medical steroid in every dose is quickly used up by the body. Therefore, you need to top it up each day. If you skip inhaler doses because you feel better, the steroid level drops, so your lungs are less protected against overreacting and are out of balance more easily. On a side note, the medical steroids in your inhaler don't have anything to do with the bodybuilding anabolic steroids which athletes use to look like Arnold Schwarzenegger. The reliever inhaler works differently to the preventer inhaler. It only treats the symptoms when they are already there. It can take away the tightness in the chest and make yourself feel better in that moment, but this does not get to the real cause of the problem. This is because the reliever will not help in keeping the balance in your lungs at all. It does not protect your lungs from overreacting. Only your preventer can do that. Therefore, the preventer is actually more important, as it can prevent symptoms from happening. So remember, your asthma is caused by your lungs reacting too strongly. And even though it feels like your asthma comes and goes, it is actually there all the time, because your lungs are prone to overreacting. By using your preventer regularly, you keep your lungs in balance to put your asthma in the background so you can get on with enjoying your life.
I think here there's a real important educational piece around what the importance of the preventer inhaler is compared to that blue inhaler. And perhaps this is something that we can do going forward in group consultations, where we identify those patients who are using lots of their blue inhaler and not using any of their preventatives. And I found in practice, when I have these conversations with patients, it does sometimes change their behavior. We also know that over-reliance on salbutamol inhalers is associated with an increased risk of severe exacerbations. And I'm sure it comes as no surprise to you that as the number of salbutamol canisters increase per year, so does the risk of hospitalizations, emergency department visits, and overall oral corticosteroid prescriptions increases as well. So again, one of the ways that we can think about reducing this is thinking about MART therapy. I'm a huge fan of MART therapy. So MART therapy stands for maintenance and reliever therapy, and it includes inhalers that contain formoterol. I'll come back to that in just a second. We'll just discuss this study here. So this was almost a year-long study, recruiting about 850 patients into each arm. What they did was compared the use of as-needed salbutamol to as-needed beclomethasone containing formoterol. What they found was that at the end of almost 12 months, patients with using salbutamol had a higher had significantly higher rates of exacerbations compared to patients using just formoterol and beclomethasone combinations. So the benefit of using formoterol is that it's a full agonist and it binds to the receptor site just as quickly as salbutamol does. So it exerts that bronchodilation in the same way. But the benefit of formoterol over salbutamol is that formoterol stays in that receptor site for up to 12 hours. So not only does it provide that bronchodilation, you also get that anti-inflammatory effect from the beclomethasone. So therefore reducing that risk of exacerbation. What about in severe asthma? So we've learned about preventative measures, absolutely, it has a huge role. But what about if a patient is experiencing symptoms and they're needing to use their Symbicort or their Foster or their Durarest? So this was a study published quite some time ago now in 2003, which compared formoterol turbohaler at the maximum dose to salbutamol PMDI via spacer at the maximum dose as well, and that was given over 1 hour. It included 88 patients, and it was a double-blind, double-dummy randomized controlled trial. What they found here was that formoterol increased FEV1 at 75 minutes by 37%. And it increased salbutamol increased FEV1 at 75 minutes by 28%. This was not found to be statistically significantly different, but nonetheless, we can see here that formoterol is non-inferior to salbutamol. What's really interesting here is that after 4 hours, formoterol increased FEV1 by 51%, whereas salbutamol only increased FEV1 by 36%. And this was found to be statistically significant. So even in severe asthma, using formoterol actually has a more profound effect in terms of improving FEV1 over 4 hours. So the MART options that are currently available in City and Hackney include Foster 100/6 MDI, which can be used as a maintenance dose of 1 puff twice a day with a maximum dose of 8 inhalations per day as a reliever, or is available as the Nexthaler, exactly the same. And this is licensed for patients aged over 18. We also have Symbicort turbohaler available in the 100/6 or the 200/6. And again, maximum dose here is 12 inhalations per day. The normal maintenance dose would be 2 puffs in the morning and 2 puffs at night. And then very lastly, we have Durarest Spiromax, which is the generic version of Symbicort 200/6. Again, 2 puffs in the morning, 2 puffs at night as their maintenance, and then a maximum daily dose of 12 inhalations per day. So not only is this beneficial for the patient in terms of their reduced risk of exacerbations, but also if you think about these patients choosing between their blue inhaler and their brown inhaler, actually, if they're just using one, then we know we're getting that bronchodilation as well as that anti-inflammatory effect here. And also for patients who are paying for their prescriptions, it makes it a lot cheaper to have 1 inhaler as opposed to 2. Just going on to the prescribing of inhalers, I have seen that there are a couple of questions that have popped up, and I'll answer those right at the end, if that's okay. So prescribing of inhalers in general. So some low global warming potential or DPI prescribing options in asthma and COPD. I've just gone through a couple of examples here. So our first line low inhaled corticosteroid option is Clenil 100, 2 puffs twice a day. If an MDI is the most appropriate, then another option to reduce that global warming potential, the carbon footprint load, is to prescribe Clenil 200, 1 puff twice a day. So dose equivalent, but actually has, because you're only using 1 puff, you're not using as much propellant. In terms of cost, that would be 40p more every 30 days. So it's not going to break the bank. Another option would be the DPI option. So if a DPI is most appropriate for your patient, then the beclomethasone Easyhaler 200, 1 puff twice a day, which works out to be £4.48 per 30 days, so per month. Alternatively, you can, or if a patient is requiring a low dose inhaled corticosteroid with a LABA, then Foster, PMDI, or the Nexthaler is currently our first line option in asthma. There has been some work done at the Hoxton practice where a specialist GP registrar looked at switching patients from the PMDI to the Nexthaler where it was appropriate. This would obviously be dose and cost equivalent, however, would have a significant reduction in the carbon footprint. Ventolin and Flutiform have the worst carbon footprint. So for all of our patients who are prescribed salbutamol, I would really encourage that we prescribe this by brand. Most people are okay with the Salamol brand, but if it is indicated, then Ventolin is okay. But the most important thing is that if they have well-controlled disease, they shouldn't be needing very much of it at all. For any patients who are prescribed combination inhalers, so if they're prescribed a Clenil and then a separate salmeterol, then we want to consider combination inhalers. I think that example actually is probably less common nowadays, but we still probably have patients who are on, for example, Seretide, 250, 2 puffs twice a day, and then a separate tiotropium inhaler. So you may want to consider a combination there if appropriate. And again, device consistency is also really, really important. I've already spoken about this already. So quality improvement here, I think what my number one aim would be is to ensure that you as a healthcare professional know how to use and teach good inhaler technique. So there are some resources available. I'm hoping everybody in City and Hackney has the Right Breathe app on their phones or on their desktops, but also the UK Inhaler Competency Framework is really, really good. Before I started doing respiratory or specializing in respiratory, I was often sent to the pharmacy hatch to teach patients how to use inhalers, and I had no idea really. And it was only when someone pointed out that I was doing it incorrectly that I realized how hard it was to actually use. So number one would be to learn how to use all these inhalers. I know there are loads on the market. You just have to learn how to use a few of them, and then it does click. But I do appreciate that this is my specialism. So if you can just learn how to use a PMDI or identify when someone isn't using it correctly, and that's all I ask for at the moment. Thinking about improving disease control, so obviously smoking cessation is really important. Pulmonary rehab, we are doing some work as a CCG to identify patients who are eligible for pulmonary rehab, and hopefully encouraging them to sign up, because not all breathlessness is attributed to asthma and COPD, but unfortunately these patients have become so used to using their salbutamol inhalers when they do experience some degree of breathlessness. So pulmonary rehab is really, really good, and I think that will also help reduce some of this salbutamol use. Vaccinations are really important, as you all know. I won't go into that so much. And I think my number two priority here would be to reduce waste. So a long time ago, when I used to do home visits, I've seen so many inhalers being wasted. Patients are receiving, a salbutamol inhaler every month. They're receiving their preventer inhaler every month, and often not even using these correctly. So we really need to find this inappropriate issues and encourage inhaler recycling. There's an asterisk by inhaler recycling because this isn't really something that's available at the moment, but something I think that we are looking into doing. Patient activation and self-management also, so in one of my earlier slides, I said the journey to the GP practice or the hospital actually has far greater carbon footprint than using inhalers. So if these patients know how to manage their symptoms correctly, they know how to get on top of things quickly, then actually that reduces them having to travel to GP practices or the hospitals, also reduces the burden on the NHS. I think one thing that's really, really important is that we also identify patients who are frequently exacerbating. So for any asthma or COPD patient who's had 2 or more courses of oral corticosteroids, I would suggest we refer these patients, because it might not be asthma that's causing these symptoms, but they may be taking inappropriate oral corticosteroids, and actually that leads to other comorbidities. Often I've seen patients who have had 12 oral corticosteroids issued. We issue them as self-management, as rescue packs, and actually it's not their asthma or COPD, it's something else that's causing their symptoms in the first place. And just my last point here is that not all breathlessness is asthma or COPD. Often I think as a pharmacist, we're probably a bit more thinking about medication, but thinking about these patients holistically actually is also really important, especially with actually both asthma and COPD. There's a lot of anxiety and depression as well that these patients experience. So often when they are feeling anxious, they'll reach out for their salbutamol inhalers, and that change in behavior does take some time. And maybe that they need psychology and not medication. I've just included this here because I thought it was really interesting when I read this paper, and just looking at all-cause exacerbations for asthma and COPD. So when we look at the mean number of admissions per week in 2018 and 2019, they're very similar, but actually there was a significant reduction in admissions in 2020. There have also been reports in primary care reductions in exacerbations as well. So perhaps there are some lessons that we have learned from the COVID-19 pandemic. We know that exacerbations are often caused by viruses, and that's usually the rhinovirus. So actually, is this because there was an improvement in hand hygiene during this time? Is it because there was a reduced exposure to viruses due to isolation for many of these patients who were considered to be high risk? Is it because in March 2020, all of these patients with asthma and COPD rang up requesting their brown inhalers and their blue inhalers that they hadn't had for many years, and led to an improvement in adherence during this time? Or is this because of better self-management? Did they get better at using their inhalers when the symptoms got worse, or were they taking their rescue packs better and reducing the number of times they were going to a hospital? I don't know. So how this all aligns with the DES contract. So we want to increase the number of patients that are regularly prescribed inhaled corticosteroids where indicated. So the aim is by 2024, 2025, 90% of patients on the asthma register will be regularly prescribed inhaled corticosteroids. There needs to be a reduction in avoidable SABA prescribing, and only 10% of patients should be prescribed 6 or more SABA inhalers per year. There should be an increase in DPI or soft mist inhaler prescribing by 2023, 2024, and only 25% of non-salbutamol inhalers prescribed will be PMDIs. I do not advocate switching patients without consultation, but I think I have justified some of the reasons here today why we should be switching patients from PMDIs to DPIs, mostly because of their inhaler technique. And if we are prescribing salbutamol, then we're prescribing those with lower carbon intensity propellants, such as Salamol, as opposed to Ventolin. What I think is really, really important here is that we recognize that things are not going to change overnight. Even with MART therapy, for example, to say to a patient that you should never be needing to use your blue inhaler again, we're not going to prescribe it for you again. Your Foster or your Symbicort should be enough. It's probably going to make them quite anxious. So what I've done in practice is prescribe them their MART regime. And I've said, it's okay, you can hold on to your blue inhaler for now, just because they know it's there in case. So it might take them that year to recognize actually that their Foster or Symbicort or Durasp or whatever it is enough, and they don't need their blue inhaler and they shouldn't need to prescribe it again. And similarly, where we educate patients that their preventative inhalers in asthma should be enough and they shouldn't be needing to use their blue inhalers, to change that behavior of them not having that blue inhaler in their drawer or their coat and their bag and everywhere else that they may be, that behavior change is going to take time. So things are not going to change overnight. So I think we just need to recognize that this is a long-term change rather than something that's going to change tomorrow or next week. That's everything I have to say at the moment for inhaler prescribing. Thank you very much for listening. I know there are some questions in the Q&A. I'll just go through them now. Is there a... Oh, Usma, you're going to answer this?
I was trying to search for your video that you showed, but I couldn't get the link. Are you able to share it with the rest of the group?
I'm not actually allowed to share that video because it was part of a PhD that I was supporting with Rob Horn. So I'm not actually allowed to share that video, I'm afraid.
Sorry, Sharoni, you can't share that.
Sorry. Heggy said, we still have, hi, by the way, we still have got the ongoing problem of diagnostic spirometry. You might be coming on to this later. I recently asked ACES to do spirometry, but they declined. Obviously, we can do peak flow diaries, but this isn't as useful as diagnostic COPD, diagnosing COPD. We are now advocating that you do spirometry in GP practices. Could have been some information sent out to everybody. I don't know if you want to unmute yourself. I don't know if you're able to, but there is information. I'm happy to email you if you haven't had this. Alana, is she allowed to unmute herself? Do you know?
Yeah, if you just raise your hand. Yeah.
Okay.
Yeah. There you go.
Sorry, Heggy. No? Okay, sorry. Heggy, we can talk about it later. You can, if you send me an email, I'll tell you about spirometry. Claire, hi Claire. I thought it was recommended that we should be using Clenil 100 2 puffs twice a day as it gets better deposition compared to, no, not at all. There shouldn't be any reason why you don't get the same deposition. As long as the inhaler technique is good, there is no difference between the two. So in terms of the carbon footprint, it would be highly beneficial just to use that 1 puff as opposed to 2. Victoria Holt, hi. Surely the reduced exacerbations in 2020 was also due to wearing masks. Yeah, more than hand hygiene. Yeah, we don't know. It may have been, but a lot of these patients were also shielding, so we don't know. So they were all question marks. We don't know what the cause of the reduced exacerbations was. Can Lufrobec be prescribed instead of Foster? Thanks, Natalie. We don't have that on formulary at the moment. The reason we've kept to Foster is because we don't want to have hundreds of different inhalers on the formulary. So at the moment, it's just Foster that can be prescribed. Any more tips, recommendations when switching MDI to dry powder? Yeah, so I guess my recommendation would be to ensure good inhaler technique. It kind of depends on which devices you're looking to try, but there is a inhaler guide included in the COPD guidelines as to which device might be best for the patient, depending on whether they want to use it once a day or twice a day, depending on what their inspiratory effort is like. When we go back to, I guess, normal reviews, you could also use an in-check device to determine what the patient's inspiratory effort is like. But I think we're a little bit away from that just because of infection control. I think I saw some hands up too, but I don't know how to check. Sorry, Alana.
Petal Mayuri has her hand up.
Okay, hi Mayuri. Hello?
Yeah, I've allowed Mayuri to talk, so she should be able to. Maybe it was an accident. If anyone else has any questions, you can raise your hand.
Can you hear me?
Yeah.
Good. Sorry about that. I need a headset here. What I was saying, Hetal, thank you for your presentation. It's really helpful. If there's any information that you want to pass on to the practices, we can put something in the newsletter. So if you've got any links, any information about the spirometry, etc., that you want to share, happy to share that with the practices.
Yeah, thank you, Yuri.
Thanks.
Are there any other questions?
Can I raise a question, Hetal?
Yeah.
Sorry, it's Rosalia. I'm trying to find out how to raise my hand, and I thought, oh, let me just start speaking, because otherwise the session will end. I joined late, so apologies for that. So I missed the first 13 minutes or so. But I wanted to find out if people are having the MART regime and also have quite regular salbutamol. Can you talk to us about the risks of, if any, of continuing sort of relatively high levels of salbutamol? I know you'd want to look at, what's the underlying reason why they continue to kind of have symptoms, etc. But
Yeah.
could you just maybe discuss briefly what the risks are around regular salbutamol and having formoterol, etc., through the combination products? Thank you.
Yeah, so they shouldn't really be needing to have both salbutamol and formoterol. So I think you've kind of hit the nail on the head a little bit there, where you said it might not all be because of asthma. A lot of these patients do have a lot of anxiety around stopping salbutamol. I think what we need to think about is how we get that good control. So it's finding out or trying to establish what their baseline maintenance therapy should be. So if a patient, for example, is on Clenil, and they're using 2 puffs in the morning, 2 puffs at night, but they're also using 5 puffs of their salbutamol a day, for example. And then we consider that they go on to a combination inhaler like Foster, then we need to think about what dose is going to keep them well controlled in their baseline. So it may be that for that particular patient, I would start them on for Foster 100/6, 2 puffs in the morning, 2 puffs at night. So I'm increasing their dose of inhaled corticosteroid. I'm also giving them a maintenance dose of their long-acting beta agonist. So that long-acting beta agonist should be sufficient to keep their asthma as well controlled as possible. In the meantime, if they are then feeling breathless and they're feeling tight-chested, they can use one other dose of Foster. If they are needing to use that more than 4 times a day, so they're using the maximum dose of 8 puffs a day, then they need to come back, and then we need to review that again. So that might not be the most appropriate way forward. But a lot of the benefit of MART therapy is really for those patients who are using a lot of salbutamol, where they get that long-acting benefit as well as that immediate reliever use using the formoterol, if that makes sense.
Thanks, Hetal.
Is there another question in the Q&A? It would be great if you could write the suggested schedule down. Yeah, okay. Yeah, sure, Heggy. I can send that to you. I guess the thing is, it's not that straightforward. There's no black and white to this, and it's really about trying to establish what the best regime is for the patient. So anyone that's using lots of their salbutamol and just on an inhaled corticosteroid without a long-acting beta agonist, beta agonist, should be on a longer-acting beta agonist, so we reduce that salbutamol use. Again, if that doesn't work, if a patient is using a lot of their salbutamol, then I would be looking at what is triggering their asthma, whether it is a pharmacological reason. So is it triggered by changes in weather, or a new cat or a dog, or pollen count, for example, or is it actually driven by a different comorbidity? Are they deconditioned? Is it when they go out for a walk that they're using their salbutamol then? So it's not as black and white, but I'm happy to send you that. Will there be an asthma action plan available for MART regime, as the current one does not apply for that? Yes, I believe that the pharmaceutical industries actually have a MART regime for their specific treatments. At the moment, we haven't uploaded that onto EMIS because it can get a little bit much, but I think it is something that we will hopefully be doing in the future. Would be good to have on EMIS. Yeah, perfect. Any other questions? Yeah, Heggy, actually, I think that's a really good idea with examples, and perhaps I can make a note of examples going forward. as part of this webinar where I can make suggestions of treatment options. Yeah, that's not a problem. Any other questions? Thank you all for listening. I hope that was helpful. I'll stay on just in case anybody else has anything. No problem, Heggy. Nice to see you, kind of.